it is my big honor to be invited to this course, and I wish gratefully that we could meet physically next year. So when we first start to learn interventional EUS, at least for me, I was given this quote by my predecessor, telling me that in interventional EUS, when you succeed, you become a hero because you were able to perform a procedure that many have failed before you. But during the procedure, if you fail miserably because no one would understand you, and some may even say some very harsh words about you attempting procedure which is very difficult. But after gaining so much experience on interventional EUS, really, there are some ways that we can deal with the complications encountered during interventional EUS, and these are my views. First of all, originally we have one problem to deal with, but now you have created another one, so you have two problems to deal with. So you have to ask yourself a few questions. First is whether you can deal with it yourself. Should you continue with the procedure, or should you go to a salvage procedure? If you continue with the procedure, you need to think what happens if you fail again. Could the patient tolerate another failure? And is there someone in your unit who could do a better job? If yes, then definitely ask for the person's help. And also you need to think whether you need to involve other disciplines as well. In terms of interventional EUS, these are the most commonly encountered issues. Stent misdeployment is one dreaded complication, particularly to those who are just starting to the procedure. Stent migration sometimes occur. It can be early or late. If it happens early, it can be problematic. Stent blockade is similar to any type of drainage procedures like ERCP or duodenal stents. Perforation is maybe an intentional perforation or an unintentional. Food impaction. Nowadays, we're seeing more of these sort of issues, particularly when the stent is placed in the stomach. Then we may see more of the issue of food impaction, and finally bleeding. So in my view, the first 5 of these issues most of the time could be dealt with endoscopically. Bleeding can also be dealt with endoscopically, but sometimes it could be quite severe. So we may need a multidisciplinary involvement. Regarding stent position or migration, I just want to show you a few cases to share, to see what we can learn from these cases. This is a case of EUS-guided coloduodenectomy. It was a case performed in Columbia University by our friend Amrita. And it is a video taken from my new book, Strategies on Interventional EUS. So this is a patient who has a unresectable pancreatic cancer. They were attempting to perform a CDS using the hot axial system. The duct was dilated, so they performed a direct puncture. And this is what happened. So right here, the scope position is a long position. This is the dilated CBD. They perform a direct puncture. Okay, oops. So right there, the stent delivery system was inserted into the duct, but you can see the hilum is towards this angle. So because the axial system is quite stiff, so it's difficult to push it, to negotiate the axials up the duct deeply. So anyways, they decided to open the stent right here. If you look at the EUS view, This should alert you that the stent is actually opened outside the duct. This is the bile duct. The stent is backward deploying, meaning if the delivery system is not inserted deep enough, the tip of the delivery system is inside the duct, but the stent could open backwards so that the flange, distal flange, is between the duodenum and the bile duct. So right here is quite clear. So to salvage, I think they inserted a guide wire, but finally they deployed the entire system. So the stent is outside the bile duct. To salvage, they were very lucky enough that a guide wire could still be reinserted through the axials back into the bile duct. Followed by insertion of the balloon deep inside, contrast injection, but see there's some leakage. And with the sweep of the balloon, the contrast is coming out. So at this juncture, we need to deal with this leak from a bile duct. But with the guide wire in situ, so an additional stent could be inserted to seal the hole inside the bile duct. So a stent-in-stent procedure was performed, and there's no more leak afterwards. Another procedure, a EUS-guided transgastric ERCP for rural and wide gastric bypass. So in patients with rural bypass, the excluded stomach, it's very difficult to do a ERCP. Food is very ruling. So one way is to perform a gastrostomy and to perform ERCP through the stent. So another video taken from the book is from Reem Sharaha from Cornell University. So the first part of the procedure is to perform a gastrostomy. The stomach was punctured and distended with contrast, stent deployed, and proximal flange opened. Then a transgastric ERCP is performed. And then finally, I think a metal stent was inserted. But as the scope was withdrawn, you can see right there, this is the proximal flange. This is actually the peritoneal cavity right there. So because this procedure was performed in the same session, the stent was actually pushed out from the remnant stomach. So there are two ways to deal with this issue. One is to try and pull the axials back into remnant stomach, but may not be easy because the proximal flange is fully opened. And in this case, Reem decided to put in a additional esophageal stent on stent, like this way. Followed by anchorage of the stent to the mucosa. So if there is any chance of stent migration, stent misdeployment, the main aim is to try to reinsert another stent to bridge the two lumens. And if you are successful, most of the time these patients would be well procedurally. So stent migration can also occur in other procedures like HGS. For HGS, it's definitely one of the most difficult types of EUS biliary drainage. There are a number of reasons. For example, a smaller duct, guide wire manipulation, stent placement, stent related complications. Right here, I want to show you this X-ray is that you have to realize if you see this sign, which is a double narrowing sign, it means this is the site where the stent is coming out from the liver. And this is the site where the stent is entering the stomach. So there's a long intragastric portion. So if this happens, you need to be careful because if there's a long intragastric portion, the amount of stent inside the stomach may become shortened, and this may increase the risk of migration. So for HGS, we usually try to have at least 5 centimeters in the stomach. There are a number of ways to salvage, like stent on stent with my stenting migration properties, and also methods like the crisscross anchoring and clip flat method. This is the crisscross method, which was first described by Isayama. You put 2 guide wires in the cross manner and then insert 2 PD stents. Of course, another way is to do a clip flat method. Put some clips on the stent, and these clips may act as flaps, but personally, I'm not too sure if it is a very strong way to anchor the stents. Regarding EUS-GJ, there has also been a paper describing the classification outcomes and management of misdeployed stent. So a misdeployed stent in type 1 is the misdeployed stent in the stomach. So the distal flange is not in the duodenum, but the proximal flange is the stomach. Type 2 is an enterotomy was opened in the duodenum, but the distal flange is not inside. The most common type is type 1. The second most common type is type 2. Type 3 is the least common type, where the distal flange is in position, but the proximal flange was deployed outside. And finally, the gastrocolic deployment, which sounds terrible, but actually not that difficult to manage. So if you look at type 1, most of the time these are just mild AEs. Type 2 as well, mild AEs. For type 3, this was a fatal type of AEs, and for type 4, it is only a moderate AE. In terms of management, type 1, there are a number of ways you could do it. You can do a same session EUS-GE, pull out the stent, close the opening, and try to insert another stent, or do a same session duodenal stent. For type 2, similarly, you can do it the same way, although the small hole may give you in the duodenum may give you problems afterwards. And for type 4, in fact, the stent should be left in situ, but maybe after a week or 2, you could come back and pull out the stent. The fistula is already well formed, and you can close the opening. Perforation, this is a case of EUS gallbladder drainage. First half of the procedure was very smooth. Distal flange deployed, proximal flange opened. And this is where the problem happened. So I was trying to look at the lumen of the stent. So I was doing this torque maneuver. But then when I talked right there, suddenly I saw the peritoneum. So I was very scared. I pulled back the scope. And then right here, a lot of blood. And right there seems to be an opening. So what happened was I actually perforated next to the stent. So this is a very newly placed stent. This is the hole. So I went between the duodenum and the stent. So this is something that you need to be aware that could happen. So try not to do too many manipulations after the stent placement. For this patient, I was able to close the opening after multiple clips. Right there. And to my relief, after closure, no more contrast leakage. So I was lucky. So another unusual case. This was a patient who had HGS. So we looked around, we found a dilated segment 3 duct, we assumed. We punctured, we inject contrast. So it is actually the common left hepatic duct. This duct is, on hindsight, a bit tortuous. So segment 2, segment 3, common left common hepatic duct coming down and then going back up, and then this is the CBD. So the wire will need to go this way in order to enter the CBD. So after some manipulation, the guide wire was able to pass to the left IHD and then back up to a segment 4 duct. We then proceeded to a dilation of the tract by cystotome. Afterwards, we tried to insert the geoball system. Now, this system, already you can see we have some difficulty on pushing the stent because this is just the uncovered portion and we need this entire portion within this part of the duct. So I was supervising at the time, so the endoscopist kept pushing, I was wiggling the wire, and then suddenly this happened. So the stent went forward, the wire is still in the duct. Still, we weren't sure what happened. So we pulled back the delivery system. I tried to manipulate the wire, not 100% sure where we are. At one point, we thought we might have the cystic duct, and then the guide wire went through this area, which looked like the gallbladder. Anyways, we changed back to a cystotome and inject contrast. So now we knew what happened. So this is a false track. So the delivery system actually double punctured, went into the duct, and then double punctured the opposite duct and went into outside, which I don't know where. This wire is not in the right position. So at this point, we were trying to see if we could try to recannulate into. And then this side is still the IHD, left IHD. So this side is still inside the duct. So at this point, I was thinking we should try to manipulate the wire back in the system, deploy the stent inside the left IHD. The false track should heal by itself if we have good drainage. So luckily, we were able to manipulate the guide wire back into the left system. And the plan is just to place the stent here, not into the false track. We used the original geoball again, but because the geoball has an uncovered portion, so we were expecting the uncovered portion to be extending into the liver. So all this will need to be covered later by another fully covered stent. On hindsight, we probably could have used a fully covered stent instead of a geoball. So this is inside the liver parenchyma, so we cannot leave it like that because there will be leakage. So we decided to deploy the stent and put a stent in stent and then perform stent in stent. So right here you could see probably wasn't the best decision because all this system was very floppy. The stent is not very well expanded. The tip of the second delivery system was very difficult. It took us ages to advance into the stent. And I had to be extremely patient, moving millimeter by millimeter. And then after a very long trial, finally delivery system inserted deeply. We opened the fully covered stent inside the geoball. And then inject contrast, no more leak. Okay, so this patient actually recovered very uneventfully, but of course it was a very difficult procedure. So in conclusion, tips and tricks, most importantly is to have good planning, decide where to puncture, always have a plan B.
Hello, everyone. This is Pratik Sharma from Kansas City, and it's my pleasure